Good morning, everybody. Welcome to our Trainees Research Award presentation. This is the first of two sessions. We'll be doing another on April 7th. And congratulations to our two awardees, Megan McHale and Simar Singh. We are happy to do this every year to recognize some of the best research that's being done by trainees in our department. Generally, the applications for the Trainee Research Award go out in sort of November and with a due date in January. So any of the trainees who are thinking about it, keep your eyes open for that. And please, we would love to celebrate everybody's research, and it's really fun for us to read the applications. I should thank the committee, which includes me, Andrew Crystal, our vice chair for research, Dave Manoli, Dan Mathlon, and Marina Tulashams.
Good morning, everybody. Oh, geez, sorry about that. Good morning. We're going to hold questions to the end. It's been such a joy to see both of these trainees develop into the stellar scholars that they are. Dr. Singh earned her BA in psychology and integrative biology at University of California, Berkeley. And she also earned her PhD in clinical psychology at Drexel University. We were then fortunate to recruit Dr. Singh to here for our clinical services research and training program, where I was privileged to be able to co-mentor her with Dr. Daniel LaGrange. Before her arrival for postdoc, Dr. Singh had actually already served a stint here at UCSF, working with both Dr. Nikki Bush and Dr. LaGrange, where she had already made an extremely positive impression on all of us. She's incredibly meticulous. She delivers such high quality work, which you'll see today. And she's been instrumental and a fantastic contributor to the eating disorders field at large. So without further ado, please join me in a warm welcome for Dr. Simar Singh.
Okay, thank you for that lovely introduction, Sasha. So today I will be sharing some brand new findings on mealtime behaviors during the family meal in family-based treatment for anorexia nervosa. These findings haven't even been published yet, so you all are really the first to be hearing about the fun work we've been doing here. I have no disclosures. And as an overview for today, I'll begin by providing some background. Then I'll discuss the current study and end on future directions and conclusions. Before I get started, I want to thank some really special people on this project. So Dr. Catherine Jury, who is a dear friend and has been a very close co-collaborator on this project. And then our phenomenal video coders. We wouldn't have any of this data without their talents. So, you know, this project is really all of their hard work. So thank you all so much. Megan did a wonderful job of orienting us to eating disorders more broadly. And today I'll be taking us on a deep dive into anorexia nervosa, which is an eating disorder characterized by weight loss, difficulties maintaining an appropriate body weight for height, age, and stature, and in many individuals, distorted body image. Now, anorexia will typically onset in adolescence, so around 15 years old. And just like with any other mental health disorder, we want early and we want effective treatment. Now, family-based treatment, or FBT, is our best available treatment for anorexia. The problem is that our best still isn't that great. So over 1/2 of adolescents who have received a full dose of FBT will still remain symptomatic at 1-year follow-up. Which then leads us to this crossroads. Are our treatments ineffective because there are simply way too many barriers to receiving care? Or maybe our treatments are actually good, but we are just not delivering them well. So could this be an issue with treatment fidelity? Maybe we do indeed just need to develop entirely new treatments. What we're doing is, simply not working. Or perhaps we identify for whom treatments are not working and then adapt them. So Megan did a nice job of discussing barriers to treatment, and today I will be discussing one treatment adaptation. So one of the best predictors of treatment outcome in FBT is going to be early weight gain. And when I say early weight gain, I'm talking about an oddly specific number, which is going to be 2.4 kilos, or about 5.3 pounds, by session 4 of treatment. So people who meet this benchmark, we will call early responders. And then people who fail to meet this benchmark, we call non-responders. And Dr. LaGrange, in collaboration with Dr. Jim Locke at Stanford, developed this pretty neat treatment for these non-responders. And what we can do is we can give them a 3-session booster of FBT that we call intensive parental coaching, or IPC, to almost supercharge them and get them back on track for favorable outcomes. And indeed, we do see that IPC is effective, and it's especially effective for families whose parents have low self-efficacy. So the flow treatment would look something like this, where everyone receives standard FBT in sessions 1 through 4, and this will include a family meal session in session 2. And then our patients who gain those 2.4 kilos by session 4 will continue on with FBT as usual. But our patients who fail to gain those 2.4 kilos will receive IPC in sessions 5 through 7. So in session 5, as therapists, we try to remobilize families by underscoring all the medical complications of anorexia, the increased likelihood of death. In session 6, we will do a second family meal. And then in session 5, we meet just with parents alone, and we focus on problem solving the barriers to progress and to weight gain. And afterwards, they continue on with FBT as usual. And today, as you probably guessed from the title of this presentation, we will be talking about those family meal sessions. So the family meal is a key intervention in FBT. If you are not doing the family meal, you are just simply not doing FBT. And what we will do at the end of session 1 to prepare our families for the family meal in session 2 is we'll say something along the lines of, bring a meal that you think is sufficient for your child to recover from anorexia nervosa. And that's it. We leave this vague and open-ended kind of on purpose so we can get a glimpse into parents' decision-making around meal times, and perhaps the decision-making is one barrier to weight gain. And as therapists, we have 4 main goals in this family meal session. We want to observe the family as they share the meal. We want to assess the family structure. We want to evaluate any strengths or challenges the parents have in feeding their child. And most importantly, we want to coach our parents to help their child eat 1 more bite after the child has stopped eating. And the thought process here is if we can reshape some of these behaviors and interactions, these learnings can empower parents and then generalize to real life to help them feed their child. So mealtime behaviors during the meal session in standard FBT are predictive of outcomes. So when parents use more specific prompts like, Simar, you have to eat all of your pizza, or even non-specific prompts like, keep going, you're doing great, you got this, we see that our patients gain higher weight by end of treatment. And that's a desirable outcome. We want our patients to be gaining weight. And then when adolescents eat more food and they remain engaged at the table, instead of running away, which isn't entirely uncommon for those of us that have done family meals, we see that they are more likely to demonstrate early response. But many gaps still remain in our understanding of the family meal. So even though we know that IPC is effective for families, we have no clue how the IPC family meal predicts outcomes. And even though the goals of the family meal are to reshape behaviors and interactions, everything we know about the family meal through published research focuses only on those individual behaviors. So we have no clue how mealtime interactions predict outcomes. For example, a child crying followed by parental warmth could lead to weight gain. But reinforcing these behaviors could also take attention away from eating and then reinforce weight loss, in which case maybe we want to focus on planned ignoring and just keeping attention on the meal at hand. So that leads into the motivation for this study, which is if we can understand which behaviors and interactions associated with desirable or undesirable outcomes, can we make treatment more effective? So here we had 3 primary aims. We wanted to understand how do adolescent and parent mealtime behaviors during the first family meal predict early response at session 4. Among responders only, how do mealtime behaviors during the first family meal predict end of treatment outcomes? And then among non-responders only, how do changes in adolescent and parent mealtime behaviors from family meal 1 to family meal 2 predict our end of treatment outcomes? And finally, we had 1 exploratory aim. So to understand how dyadic interactions predict early response in treatment. This is a secondary data analysis of a randomized controlled trial that compared family-based treatment against family-based treatment plus intensive parental coaching for non-responders. So to be included, adolescents needed to be between the ages of 12 to 18 and have a DSM-5 diagnosis of anorexia nervosa. And after accounting for missingness in our videos, we had 87 family meal 1 videos and then 17 IPC family meal videos. For outcomes, we looked at the Eating Disorder Examination, or EDE, which is a semi-structured interview that assesses eating disorder psychopathology. So this covers restraint, eating concerns, shape concerns, and weight concerns. And here, higher scores equal worse outcomes. And then we also looked at estimated body weight, which was expressed as a % of median BMI. This is our measure of physical recovery. And here we actually want higher scores. So we want our patients to be closer to 100% of median BMI. As part of the trial, sessions 1 through 8 were taped for fidelity. And our coders were trained in a validated coding scheme in which they selected 1 patient and 1 parent code for every 30-second interval. And they selected these codes based on a hierarchy. So if there were 2 behaviors that occurred in a given 30-second interval, coders coded the code that was higher up on the hierarchy. So here you can see a screenshot of one of our coders' codes for minutes 0 through 5. And they repeated this for minutes 0 through 60 for parents and children. So I hope we can all appreciate just how immense of an effort this was on their behalf. So these are all the behaviors that we coded for the adolescent. There are a lot of behaviors here, and you can imagine that if we were to run models on every single one of these behaviors, we would be running hundreds of models. So what we did is we took these codes and we condensed them based on clinical relevance. So for adolescents, this included nutritional intake, food restriction, negative affect, meal arrangement, food approach, and then positive talk about food. And similarly, these are the behaviors that we looked at for the parent. And again, we condensed these codes. So here we looked at meal preparation, comfort, offering food, verbal criticism, parental conflict, and modeling eating. So here is a breakdown of all the behaviors we looked at both family meal 1 and family meal 2. And these are expressed as a percentage of the session, and that is just consistent with how the original coding scheme had analyzed their behaviors. So when we look at our adolescent behaviors, we see that across both family meals, 1 and 2, nutritional intake and food restriction occurred most frequently. And then food approach and positive talk about food occurred least frequently, unsurprisingly. And then for parents, again, across both family meals, we see comforting and eating occur most frequently, and offering food, verbal criticism, and parental conflict occurring least frequently. So onto our findings for AIM-1, we found that our adolescent and parent behaviors indeed predicted early response, and this is during the first family meal. So here, if an adolescent was a non-responder, they were coded as a 1, and if they were an early responder, they were coded as a 0. So an odds ratio greater than 1 indicates an increased odds of non-response, and then an odds ratio less than 1 indicates an increased odds of early response. And I know these odds ratios are small, but they are consistent with our clinical intuition. So it's unsurprising to us that adolescents who expressed more negative affect and who refused food more were less likely to gain weight early and meet those early weight gain benchmarks. And then for our parent behaviors, there was only one behavior that emerged as a significant predictor, and that was modeling eating. So parents who spent more time modeling eating during that first family meal were more likely to have adolescents who indeed responded early. For AIM-2, among non-responders only, we found that only adolescent behaviors during the first family meal predicted our end of treatment outcomes. So specifically, greater food approach and greater meal arrangement behaviors predicted worse EDE scores at end of treatment. And I know these findings might seem counterintuitive at first, but I think it's helpful for us to conceptualize how anorexia can hijack some really well-intentioned behaviors. So food approach is not the same thing as eating. And it is possible that an adolescent might spend more time approaching food rather than eating as a way of delaying the meal. Or maybe they actually approach the table in good faith, but because eating is so scary and so overwhelming, we see their EDE scores really spiking. And then with meal arrangement, adolescents might feel compelled to choose a smaller plate or smaller utensils to avoid eating larger quantities of food. Or maybe even including the kid in meal setup almost supercharges perseveration. So as they're laying the table, setting the plates, setting the napkins, putting silverware, they just have a lot more time to dwell and think about the meal that's to come, hence the positive relationship with EDE scores. And this finding is a little more straightforward. So the more negative affect that was expressed during the first family meal, the lower the non-responder's weight was at end of treatment. So if emotional distress is going to be a barrier to weight gain, then we really want to focus on skills coping during meal times. For AIM-3, among non-responders only, we found that changes in both adolescent and parent behaviors predicted our end of treatment outcomes. So here, when we calculated change scores, we subtracted our family meal 1 behaviors from our family meal 2 behaviors. So positive scores, anything to the right of the dashed line, indicates that the behaviors went up by the second family meal. And then negative change scores, so anything to the left of the dashed line, suggests that these behaviors went down by the second family meal. So here we see that increases in adolescent restriction actually predicted better EDE scores at end of treatment. And I want us to remember that in session 5 of IPC, so right before the family meal session, as therapists, we are trying to remobilize families. So we are underscoring every single medical complication of anorexia nervosa. We're telling parents that their child might die. So it's possible that a message resonated with families, and maybe parents brought more challenging meals to the second family meal, hence the increase in restriction for some kids. But maybe the therapist is more able to effectively coach the kid during that second family meal, hence the decreases in EDE scores. This was a complicated finding that we had a hard time wrapping our heads around, and that was the best explanation we could come up with. However, it also seems that if therapists were able to more effectively coach the kid during the second family meal, so decrease their negative affect, we do see increases in percent median BMI at end of treatment. We also see that increases in parent meal prep predicted better EDE scores at end of treatment, and at the same time, decreases in adolescent meal arrangement predicted a higher percent median BMI. And I grouped these two findings together because I think they nicely highlight or complement our FBT principles. So we want parents to be in charge of every aspect of meal prep and feeding, while reducing our adolescent involvement as much as possible, even if that is in meal arrangement. And we do this because when our adolescents are so deeply entrenched in their eating disorder, it can be difficult for them to make decisions about what to eat, how much to eat in order to recover. So we want to kind of take that burden off of the child and place it on the parents, so the child has less time to ruminate or dwell on eating and food. So I think this pair of findings is a nice sanity check for why we do what we do in FBT. And then increased parental criticism and conflict predicted lower percent median BMI. And again, I want us to remember, these are parents who are so incredibly stressed. So they have been randomized to IPC because their child isn't making progress. Their therapist is telling them that their child isn't making progress. So they have every reason to be angry and to be frustrated, and maybe they're displacing some of that anger onto their child in the form of increased criticism, or even onto each other in the form of increased parental conflict. So when we think about our FBT goals more broadly, reducing expressed emotion, aligning parents is an important goal more generally, but maybe it's particularly important for these IPC families. So we could consider folding this into the IPC protocol. So in session 3, when we're meeting just with parents alone, maybe we focus on increasing alignment and decreasing criticism. Or we could even add a 4th IPC session just to focus exclusively on these goals. And then for our final finding, we found one key dyadic pair that predicted early response in treatment. So I want to preface these findings by acknowledging that they are underpowered. However, we did find that adolescent food refusal, followed by parent modeling eating, was the only dyad that predicted early response, and it was a strong predictor. So again, this highlights or underscores the importance of modeling eating for the child during the family meal, even in the face of adolescent food refusal, which if you're a parent of an individual with anorexia nervosa, you can imagine just how challenging that might be and how you might feel pulled or compelled to comfort your child. We didn't see comfort emerge at all as a significant predictor here. So we are, of course, limited by our modest sample size. So many of these analyses were underpowered, and we would like to see this work replicated in larger samples. We're also limited by our coding scheme. So we could only code one behavior for every 30-second interval. If we could code multiple behaviors for every interval, we would have much richer data to look at. And I know my coders are going to be very unhappy if they heard me say this, but I want to know about the therapist behaviors. You know, if our family meal is focused on the therapist coaching and reshaping some of these interactions, we need to know what they're doing and if what they are doing is effective. So how are families responding to what the therapists are doing in real time? I think that's also going to be really important data for us to have. And even though the family meal is great for collecting data about mealtime behaviors and interactions, it isn't representative of typical meeting or eating meal times. So, you know, families, they are coming into the office with their meals. They are eating their meals in front of a brand new therapist who not only isn't eating, but is staring at them while they're eating and then asking them a bunch of questions that they have to answer while their mouth is full of food. It's just like kind of an awkward session for those of us that have done the family meal. So if we could do the meal within the home environment, this might be a slightly better proxy for real life. And I think many of us are doing this more systematically in our regular practice, but this might be a better proxy for how meal times actually are at home. So takeaways for all of our FBT families to support both early and end of treatment outcomes. We want to increase parent involvement during meal times while decreasing adolescent involvement as much as possible. And this is not groundbreaking. This is just textbook FBT. So even though parents might be well-intentioned in wanting their kids to arrange or lay the table, this might actually backfire. And perhaps we want to focus on having our kids cope ahead, right before meal times. And then we want to increase parent modeling of eating more generally, but then especially in the face of adolescent food refusal and distress. And like I mentioned earlier, this might be incredibly distressing for parents. So maybe we also focus on building parents' distress tolerance toolkits and giving them skills to cope during meal times. And then for our non-responders specifically, we want to decrease parental conflict, so increase their alignment, and we could consider systematically folding this into IPC. So either in that 7th IPC session or as a completely new and separate IPC session. And of course, we want to decrease verbal criticism. And even though comforting was not a significant predictor, it is a great alternative to being critical of your child. I want to thank my current mentors and collaborators, the R1 research coordinators and study therapists and pediatricians, some of whom are in this room with us today. Our amazing video coders, they're so talented and really owe this work all to them. And then of course the department for the privilege of being able to present these findings with you all today. It's the first time we're sharing these out with the world, so it's a fun time for us. Thank you.
I have a quick question. So I work in the inpatient medical stabilization unit, and I'm kind of curious about how to merge the efforts that you both are, the work that you're both pursuing. So I'm wondering if there's any avenue to really work on implementing some of the work that you've been doing, Simar, around meal coaching within the medical setting, to think about, like, well, we want to keep people out of the hospital. In the meantime, we're still struggling to get access to care outpatient. Where could we bridge that gap within the resources that we have here on our program, So just kind of thinking creatively about how we can expand on the work you're doing here.
I can think of a couple different ideas, Sarah. One is, and I've worked in other settings where, you know, we've implemented these different strategies and they have been successful. So one could be leading like a parent psychoed FBT informed group on the unit to almost prime them ahead of time for what's to come. And, you know, between the time you discharge and the time you actually enter treatment, here are some quick takeaways for what you can do that is FBT consistent, that we know is the gold standard. And then another thing, which I'm not sure if we do because I haven't worked on our inpatient unit, but I've done this before, where we have held family meals on the inpatient unit, where then parents will order off of the hospital menu, and you get almost like similar goals or motivation behind the family meal, where you're looking at their meal choice, you're seeing if that is appropriate. In the setting in which I had done this before, we were not observing or coaching families through that, but that could be valuable to do, you know, like see what they ordered, sit in, observe, see how it goes. I think that might be a nice way to like preview FBT a little bit, especially if that is what the family ends up doing once they're discharged. Does that answer your question? Great.
Hi guys, it was fantastic to hear you both. Great talks. I think how we would maybe conceptualize the family meal is as an exposure, if you will, sort of transdiagnostically. It's something where we would expose something. I guess I'm curious, Simar, you know, from your understanding of FBT and sort of how it might be a little bit different, it's just sort of surprising that we would encourage the child to not engage so much with the preparation of the meal or sort of face their fear, if you will. And if you could just kind of wrap my head around sort of how it might be that the takeaway here feels like it's almost the opposite of what we would sort of normally think of like a traditional exposure.
Yes, great question. One thing that I didn't have time to mention is that in FBT, we have our different phases of treatment, right? So in phase 1 of treatment, we're really having parents take full charge of eating and feeding and nutrition. But in phase 2 of treatment, we, you know, hand that autonomy slowly over to the adolescent in a way that is age appropriate, in a way that is family appropriate. So I think what you're saying is very appropriate and what we would want to do in phase 2 of treatment. The family meals, the family meal sessions. So in session 2 and then in session 6 for IPC are in that phase 1 of treatments. It might be a little bit premature, especially because these kids, if you look at MRIs of individuals with and without anorexia, their brains are so starved. So I don't know if the exposure would have as much like bang for its buck that early on. So once we get their weight up, we get their brain, back and working and online, I think our exposures are going to be much more effective and impactful. Great question.
Well, thanks everybody for coming. And again, congratulations to our trainee research awardees.